Perfectly. Well, thanks a lot. Good afternoon, everyone. My name is Tobias Becher. I'm a clinical development lead at Roche Diagnostics International in Switzerland. And it's my great pleasure today to talk about clinical decision support in heart failure from raw data to actionable insights. As you will realize soon, this is also a project for us that is work in progress, so we're kind of collecting input and insights right now. And what I want to share with you today is our vision around what we're trying to achieve within the next years to move this field forward. So briefly, today I'll talk a bit about telemedicine and remote patient management. I want to dive a bit into the current evidence that we have for remote patient management, the challenges and the hurdles, and then again share our vision of what we try to achieve as a company within the next years. So briefly, telemedicine and telecare is defined as diagnostics and therapy that use information and communication technologies. And this can be aimed towards supporting the interaction between healthcare professionals and providers on the one hand, but also can be aimed at supporting the interaction between healthcare providers and patients. I think we kind of lost the presentation. All right, thanks. So under the segment of remote patient management, you can see there are a variety of different modalities that can be counted towards that. One is teleconsultations, so the use of virtual visits and virtual follow-ups. Disease management services and home care, such as virtual care plans that are adapted towards the individual patient needs. And lastly, also remote patient monitoring. And the bucket of remote patient monitoring is quite diverse. You see here, non-invasive measurement of vital parameters can be counted towards that. The use of biomarker measurements at home, such as blood glucose and others, or the monitoring using implantable devices such as PA pressure monitoring. So along heart failure patient journey, there are multiple opportunities to use remote patient management tools. So on one hand, we can try to increase or enhance the diagnosis of heart failure. We can identify high-risk patients and try to tailor the intensity of the management. We can try to tailor therapy and adapt dosing along guideline-directed medical therapy. We can monitor patients and identify patients that are deteriorating early and try to intervene to improve outcomes. And lastly, of course, we can try to improve outcomes overall, so reduce length of stay and decrease mortality. So there are multiple benefits so far that have been postulated for remote patient management. On the one hand, we can aim to increase access, so patients that are not usually go to their physician or live in remote areas. We can support patient empowerment, so help patients take care of their own patient journey and empower them to take their own decisions, informed with the help of a physician. We can try to improve outcomes, length of stay, readmission rates, mortality. We can try to integrate care across the patient journey, so try to connect different specialties that are involved in heart failure patient care. And lastly, we can also try to save costs along the patient journey. So what we've also noticed when developing these solutions is that there is a number of challenges along the way. So it's not as if you are implementing improvement in medical therapy or diagnostics. Here you have to overcome significant hurdles with healthcare providers, such as lack of awareness, difficulties with adoption into the clinical workflow, and lack of evidence. And on the patient side, you also have to face IT literacy and access. But beyond that, there are a number of other challenges, such as with payers, lack of reimbursement in a lot of countries right now, a fragmented legal framework and concerns with data protection and privacy. And lastly, also IT challenges where you have to match different infrastructure and resource needs, and you have to provide interoperability between different solutions. I think what we've seen during the last 2 years is that COVID-19 was one of the significant drivers for the adoption of remote patient management, and specifically here, the increase of numbers of remote visits. What you can see here on the left is data from Israel. On the top, you see the number of daily COVID-19 cases recorded, and in gray, a period of lockdown. And you can see that during this period, the number of remote visits increased significantly, and more importantly, after the lockdown, it kind of stayed increased compared to baseline, showing that there was some adoption and some benefits drawn from this kind of patient care that was significant enough to be maintained. And the other thing that you can embrace here on the left side is that we've also expanded into different areas of the patient journey. I would argue that before COVID, we mostly used remote patient monitoring in this home monitoring space, while after COVID or in the post-COVID area, we're using it in areas such as telerehabilitation, virtual visits, and forward triage. So now the question is, what kind of evidence do we have? And I just want to provide some of the evidence that I found. So this is basically highlighted in the current ESC heart failure guidelines. This is a meta-analysis from Lin et al. That looked at 39 studies that looked at telemedicine as an intervention, so teletransmissions or telephone-supported care, and looked at the impact on outcomes such as all-cause mortality and heart failure-related mortality, length of stay, and mortality. And the conclusion from this study was that overall telemedicine was shown to be beneficial, with home-based teletransmission effectively reducing mortality, admissions, length of stay, and mortality in patients with heart failure. The evidence is a bit different when it comes to remote patient monitoring, and here it really depends on what technique you're using. So if you look at non-invasive measurements such as weight and home measurements, you see that studies were mostly neutral, except of TIMI-HF. Same is true for thoracic impedance measurements and multi-parameters, where you try to merge different tools into one score. The exception is hemodynamics, so invasive measurements such as LA pressure measurements and PA pressure measurements. And this is also reflected in the current guidelines. So here from the current ESC heart failure guidelines, you see that non-invasive home telemonitoring may be considered. So it's a class B level of recommendation with a B level of evidence. And the same is true for pulmonary artery pressure measuring to guide patient management. And for ACC, I would argue that here it's even more cautious. So here they assign an uncertain value. Same level of recommendation, but here they claim the statement is it's an uncertain value. So what do we need to change in order to make remote patient management more feasible and really to drive adoption? And this is the part where I would like to share the vision that we have at Roche to accomplish that. So we believe that a final product or a solution that we're providing should be an integrated solution. And we are working towards developing, on the one hand, evidence-based disease management, so care pathways that are delivered across the IT platform and that support evidence-based care protocols on one hand, and try to merge it with different areas of remote patient monitoring. And we believe that although this may come towards a solution, there's also work that needs to be done in terms of adopting this, and this is where we think that healthcare consulting or adoption management could play a role. So here we are currently looking into data analytics and change management, and also patient pathway optimization, because we've seen from a lot of studies that although you may show a benefit of a tool, the adoption part is also equally important, and sometimes it's really difficult to tease apart what change was driven by your product versus what was driven by the adoption of that. And the final vision would be to have one, an integrated patient interface that aims at empowering patients, and two, a dashboard that could enhance patient-physician communication and support the physician in taking decisions and integrating data into something meaningful. And hopefully this would lead to a continuous interaction between the physician and the patient on one hand, and on the other hand, it would help to manage a patient, to manage their own disease with supervision by the physician. Lastly, what kind of projects are we currently conducting to drive this forward? So one development that you see here, and sorry for the problems with the formatting, is a clinical decision support platform, which is a post-acute care management solution that is built on a platform which would be integrated in the EHR and shows a comprehensive overview of the patient journey, the encounters with the physician, and the data that was collected along these encounters. And here we would use that data to provide care recommendations and algorithms along the patient journey. On the other hand, we are currently conducting pilot studies to look at different ways of remote patient monitoring and how to integrate that into this solution. So this is looking at supervised patient self-management, embedded care protocols, and medication optimization. And lastly, we are, together with Kari Lam, looking at combining biomarker measurements such as proBNP with point-of-care echocardiography that is supported by AI to improve diagnostics in the heart failure field. And then at the end, hopefully come towards an integrated solution that can be applied across the patient journey. So as a conclusion, we believe that telemedicine has the potential to transform healthcare in the heart failure space as we know it. We've seen during COVID-19 that the potential is there and that there's ways to adopt these solutions that actually lead to a benefit. However, to really drive that forward, we will need an integrated evidence generation and also measures to address different stakeholders and their concerns. And lastly, our future developments will aim towards developing an integrated solution that can be used across the patient journey. yeah, that's it from my side, and I hope with that I've inspired some questions, so please feel free to ask any of them.
Thank you, Tobias, for this fantastic opening of our Congress and highlighting kind of the new options in clinical decision support in heart failure. Please raise your hand if you have a question, and you will provide it a microphone. Please. Do we have a microphone for? Yeah. Yes, thank you.
Can I take the opportunity of the microphone?
Yes.
Congratulations, it was really fantastic presentation. I think you really opened a new door for the future of management of patients that we see in the emergency room with acute heart failure with the different phenotypes, right? We have the very critical patient that we should admit for ICU, but then we have a lot of patients that we just need to adjust a little bit the treatment. And then one question is, I have two questions. The first one is, do you need a nurse's dashboard management to telemonitoring patients? So the data are coming from the home to a nurse's station and then to the doctors. This is one question. And the second question, you mentioned the most important thing to monitoring natriuretic peptides to be this fantastic opportunity to control and predict the patients that are worsening and also prevent hospitalization. So in the second question, should you tell us how is this technology? Is it point of care? How does it work?
Okay. So firstly, I think towards your first question, that is something we're looking at is what is the best way for a physician to access the data and integrate it into the current workflow? And I don't think there is a simple solution. I think what we've learned is that we should not add additional burden to the physician. So usually physicians are very reluctant to use another app, another program that pops up, something that adds complexity to the workflow. So I think the general thinking is we need to integrate it into the EHR system. And that can be difficult depending on what country you are. We are currently working a lot in the US because here you have a market with EMRs that is a bit more focused towards Epic and Cerner, so main providers, while in Europe it's a bit more fragmented. And here I think the IT solution itself and the development of that is a major hurdle. But at the end of the day, I think the goal would be to create something which is as easily adaptable as possible to the workflow. And I think towards your second question, with Echo AI, we're currently exploring with Carrie Lam the opportunities of using echocardiography at the point of care, so training nurses to use echocardiography devices and artificial intelligence to obtain images and also to interpret them at the bedside. And here it needs to be seen if NT-proBNP can augment that either measured by a GP or if there's really the opportunity to develop a point of care device.
Richard.
Thank you very much. That was very interesting. The question I have is in our system now, we are developing the home hospital concept. So when somebody comes into the ER, as Sal said, who has heart failure or COPD, and they're older or you're a little worried, do they really need to be in a hospital at great expense? And so the pilot program is to actually those people that are sort of on the edge, you send them home. And what happens is a nurse visits them 2 or 3 times a day. The physician rounds on them in the morning. And if they feel they're getting worse, they can get directly admitted back to the hospital. And what's really interesting is that it seems to be working, and actually patients like it because they eat their own food and things of this nature. And I think it's primarily driven by cost. And so the original biomarkers would all be done in the ED, and you could repeat them, and the nurse could take them or whatever. But I think a lot of this is driven by cost. And I think when I think about it in my career out of the ER, there's many patients that were on the margin, but we thought, oh, we should admit them. And the question is, especially in heart failure or COPD, do you really need to? I mean, what happens? They sit on a ward, they get seen, 2 or 3 times a day, and of what benefit is that really? So I think this movement, however it goes, will continue, and maybe the hospital will one day become one big ICU.
Yeah, I mean, that's, at the end of the day, I think cost reduction is one of the strongest drivers that you can have, especially in the US. So even sometimes before evidence, cost reduction itself is enough to drive adoption into a system. However, we would also like to see that there is actually improvement in some of the things that we do to patients. And I agree with you also from my experience as a physician is it's not to the best effort of a patient to be on a ward for a couple of days just to be monitored and actually nothing is done. It doesn't really help the patient. So moving this actually the point of care outside of the hospital and still making sure that you can maintain the quality of your care is, I think, something that we should try to obtain with those solutions.
Okay, I think if there are no other questions, oops, thank you very much, Tobias.
Yeah, thank you very much.